I often mentor other people that are joining this field, coming from clinical care, whatever, and most of them are women. And I give them 3 pieces of advice, particularly women of color. I say, don't let the imposter syndrome stop you from pursuing your goals, because women are often considered to be imposters in this space, right? So you can't adopt that persona for yourself. The other thing is to stay curious and take risks and embrace new experiences, because women, studies show, although many won't believe that, are risk takers, right, by nature. And then the third thing, which I always tell women and women of color, is to lift as you climb. And that's sort of my motto. It's a driver for me, because then that helps others and it helps the profession improve. So those are my 3 things.
Thank you for that. Holly?
So Marjorie, I cannot believe you brought up imposter syndrome, because that's where I was going to start.
Right.
When I was in medical school, I don't remember what the context was, but there was a group of only women in medical school together. And we started talking about, well, I think that really they made a mistake when I was admitted. And every single woman in that group had that, at some level, had that feeling deep within them, which is imposter syndrome. And so I want that killed off. I just want women to be.
Right.
This is Inspiring Women, and I'm Laurie McGraw, and today I'm speaking with 2 physicians, 2 luminaries in the space of standards and interoperability. I'm speaking with Dr. Marjorie Rallins and Dr. Holly Miller. Dr. Rallins is the executive director of Loing. She has many years as a nationally recognized expert in the field of both standards data setting in healthcare, as well as interoperability. And Dr. Holly Miller is at Med Allies, and she also has 2 decades as an expert. I don't know how many different committees she is on in terms of standard setting and interoperability, but it is a lot. She's also has been a practicing physician, so she really appreciates the why interoperability is so important in the area of healthcare. Drs. Rallins and Miller, thank you so much for being on Inspiring Women.
Thank you for inviting us, Laurie.
Great. Well,
Thank you.
Sure. So Marjorie, why don't we just a little bit more on your background? I'm no way doing it justice in terms of just all of the accolades and things that you've worked on over the years. Could you just give us a little bit more of your background?
Yes, so I am a clinician and a podiatric physician by training, but most of my professional career has been spent in informatics and terminology standards, as you know, Laurie. I also add that I'm also a microbiologist, and I don't know if you know that, and began my career by working with Dr. Anthony Fauci at the Washington Hospital Center in Washington, D.C.
A national treasure. Can we just state that here?
Right. It was a wonderful experience. I was right out of college, had no idea of who I was working with, but it was a wonderful experience. But, I'm a terminologist. I'm an informatician and terminology standards, and making those things work so that we have better healthcare and better outcomes is my passion. And I've done that in a number of ways, as you know, Laurie, at the College of American Pathologists, the AMA, and now the Reconstruct, but working with many organizations. And I'm certain that I've crossed paths with Holly numerous times. So.
Terrific. Holly?
Well, I'm intimidated, Margie. Marjorie, you're such an impressive background and person, but I'm an internist, and what that is a primary care physician for adults. I became really interested in in actually health information technology. In my first job, we had a homegrown electronic health record, which by today's standards was truly terrible. But the fact of the matter is the record was available at all times and to everyone, and it intrigued me the possibilities that could come from health information technology. So I particularly was interested because it's a way of thinking of thousands of people that you can help at once, and instead of just one-on-one seeing patients every day. So I have been a managing director and had a very active practice at the Cleveland Clinic. I was the chief medical information officer at university hospitals. And then I met on the HIMSS board, Dr. John Blair, who runs MedAllies. And because the environments I've been working in had the ability for all of the physicians, they were integrated delivery networks, so all the physicians could see the same record. And he said, well, why don't you come work with us, because we have an open community where we need to figure out interoperability, because no one has information from other physicians in an open community of small physicians. So I was intrigued and I went to work at MedAllies, and since then we've evolved greatly.
Yeah. Well, so let's dive into sort of like, where we are with interoperability. I mean, first of all, standards, terminology, data sets, and how these things sort of like flow through the electronic airwaves is complex, kind of geeky stuff. Let's be honest. So when we take two physicians and we sort of, take your clinical knowledge and apply it towards this very deep technical but critical applications for how data moves around the system, I think you have a unique perspective to actually not just how to make it work, but why it is so very, very important. If we think about what interoperability intends to do, the definition, I believe, is it intends to improve quality, safety, and efficiency by engaging patients, families. It intends to improve care coordination, improve public and population health. So this is actually written into the ACA, and I would love to start with, how are we doing? How are we doing with the state of interoperability today? Maybe Holly, you could kick us off with that.
Sure, thank you, Laurie. Well, first of all, let me say that there is massive exchange going on. So millions of records are being exchanged as we speak today. That being said, the constituents that are receiving those records, so clinicians, consumers, payers, etc., don't necessarily find the data useful. And if it's not trustworthy, useful, and actionable, unfortunately, it won't be acted upon and integrated into the care. So I think there was a study that just came out that Mickey Tripathi, head of ONC, commented on, that that in fact people that are using the data find interoperability very useful. But I think the other thing that's really important to consider in our state of interoperability right now is that there are exchange networks. And if they're not on the same framework, they can't exchange with each other, which is why I'm so excited about the Trusted Exchange Framework and Common Agreement, or TEFCA.
Okay. All right. So I want to talk about TEFCA before we get to that. And I want to talk about some of those, aspects of trustworthiness, actionability, and utility. Marjorie, what are your thoughts? I mean, it's been 14 years since the ACA was put in place. So while there is tremendous progress and there's millions of records being exchanged every day, where would you sort of put it on the scale of whether those three factors, actionability, trustworthiness, utility, or do you look at it in additional ways or different ways?
Well, yeah, that's a great question. I would say that I think interoperability goes all the way back to 1996 with the, when the paper was released, To Err is Human, because that's when we first connected medical errors with our fragmented healthcare system. So that's when we really launched a focus on interoperability, and ACA was downstream from that. We've made a lot of significant progress since then, right? EHRs are much more improved because of policy and technology working together. There's better access to data. Patients have better access. We all know that. And now we have TEFCA. I would say, while we've made these great strides, there's significant work in progress that still needs to go on. Today, 70% of providers still fax results, and Holly, I'm sure you know that. And then other parts of interoperability, because it has various perspectives, are in different stages, right? And so the semantic terminology or semantic interoperability that uses CPT, LOINC, and SNOMED still has a lot of work to do, a long way to go to get where we think we need to be. And one reason for that is what relates to what Holly says, it's buy-in and adoption and what's in it for me. I think that's, that's the main place of where we are, and we don't have regulation to push us that far.
Do you mind defining semantic interoperability in more layman's terms?
Yes, I should do that. So semantic interoperability is ensuring that data or information means the same thing, regardless of how it was captured. So, things like myocardial infarction and heart attack mean the same thing, even if they're recorded differently, in standards like LOINC, SNOMED, and even CPT. And I know people, Laurie, like to say CPT is not a standard, but it is. It's its own type of standard. And it helps sort of normalize information so that we all know that we're comparing and talking about the same thing, apples to apples, and even red delicious apples to yellow delicious apples. But, when it's recorded, but those things are both apples, and we need to know that. So
Yep.
That's what semantic interoperability. There's also structural and functional and other types, but I think that's the part of interoperability that still is in development.
Okay, so let's maybe go through sort of some of those qualitative aspects of interoperability today. So the usability, the trustworthiness, and the actionability of data. And then maybe we can move to TEFCA and what that will further do, like what TEFCA is and what it will further do. But so usability, just like what do you mean by that, Holly, in terms of like how useful or not useful data is, even when it's being exchanged? Or maybe you can talk about all three of those aspects: usability, trustworthiness, and actionability. When data is flowing around, when is it substandard?
So let me start with trustworthy, because for many people that is really one of the most important things. And if you consider what could happen, having the wrong information on your patient come in thinking it's your patient's information, obviously that becomes very clear that without being able to trust the data, there's no way you even want to go near it. So there's no standard right now for the way that a patient demographics are recorded. So one EHR might do it one way, another EHR might do it another way. And therefore, as that information flows from one system to another, it may be misinterpreted, and you may end up getting data on an incorrect patient. So I think that's work that's actively being done, that ensuring that when you get the information, it is on the correct patient that you're looking for, or individual, or the individual's getting their own data.
But as a physician, when you are seeing data, about the patient that's in front of you, or you're going into the room, and that data has come from systems, whether your patient was seen in your particular clinic or a hospital or somewhere else. I broke my foot, on vacation or something like that. How would a physician recognize that the data might not be correct? How does that present itself, and how do you determine, or are there ways to determine that?
Well, I think the most important and the first step is to validate with the person in front of you. Mm-hmm. So they can clearly let you know, no, I never did break my foot. I don't know what you're talking about. So that, or, if you start, and I'm particularly talking about a new patient to
Yep.
someone. So validation is key. And one of the things I hope for, but I think this is still in some ways controversial, is that Consumers of healthcare can look at their data and correct things. So if I'm looking, or a consumer of healthcare is looking at their medication list and it's correct, but they stopped taking a medication because it gave them stomach upset, to be able to put that in their record and for their clinician to see it. So, so that's aside, but that's
If you were going to go
summary of trustworthiness.
Yeah, so that's trustworthiness. If we go to maybe actionability and utility, Marjorie, what are your thoughts perhaps about those aspects of the data as it's being moved around the big systems of, the airwaves across different health systems? How are we doing in those two areas?
I think we're doing better. So we have standards in place. So that data means the same thing. When we send it from one place to another, you move from one hospital to another, that your results are your results, or your data are connected to you in the way that they should be. And, there's all kinds of processes and protocols to help that. The challenge, as I mentioned earlier, is ensuring that the providers and the institutions adopt the protocols and recommendations that are put forth. Sometimes it comes from the federal government, right? And the federal government is very sort of thoughtful in how they regulate and mandate things. And so here in the US, there are recommendations that you should do. They're getting closer to recommendations that you must do, because a lot of this is not technologically hard. It's cultural, and it's people that have to adopt these processes and protocols in order for them to work and get adopted.
And I like the concept of also trust but verify. So physicians sort of looking but also verifying with the patient. And I also like, Holly, your recommendation from a patient perspective of having the data but also verifying it, taking proactive action as a patient to verify the data that's in front of you as a step. So let's talk about some of those sort of, advances in terms of, but beyond desired to required, in terms of what can happen with regulation. Holly, you mentioned TEFCA. Maybe you could explain what it is, what's coming, and what we should expect from that.
Well, TEFCA is the acronym for the Trusted Exchange Framework and Common Agreement. And that was really created as part of the 2016 21st Century Cures Act, which gave us all kinds of wonderful things, actually. I love that act. And TEFCA is meant to be the internet of interoperability, so really the on-ramp for interoperability. And it's designed to be comprehensive so that we can increase secure and appropriate access to data, and Marjorie, you'll love this, ensure a core set of data is available among networks connected through that common agreement. And I would emphasize that ONC takes such a huge part in this. What is the required data to exchange? And as you referenced, Laurie, it's decrease the cost, improve efficiency, provide health information networks and health IT developers with a common set of privacy and security requirements. So really, if you think about TEFCA and what it's meant to do is bring the, and I'll use the analogy of transportation. TEFCA, through the recognized coordinating entity, which is Sequoia, drew together industry constituents to develop the Trusted Exchange and Common Agreement. And these were a common set of principles, terms, and conditions to enable the exchange of electronic health information nationally. And so what TEFCA does is have has created requirements for an infrastructure technically as well as the rules of the road, that everyone who signs and participates in TEFCA has agreed to this set of principles and the conditions. And for example, that if I'm querying for a patient for treatment reasons, that is truly why I'm querying for that patient, because I'm treating the patient. And so the common agreement is really what everyone participating has agreed to. And I think that where we're going is to build this super highway where everyone ultimately will participate, all healthcare constituents.
Marjorie, when does TEFCA go into place, and who has to comply with it?
I think anyone who signs that agreement has to comply with that. So I think the agreement was signed on December 15th or December 14th, 2023. And the big announcement happened in Washington, D.C. at the ONC conference. And Holly, I'm sure you were there. Were you there?
My boss was.
Was there? Okay.
Med Allies was one of the first designated QHINs. So
right. So that's kind of how if you agree, you have to sign in and agree. And I think it starts with the QHINs, correct? Am I correct, Holly? Right.
So, yes, absolutely. And QHINs is the acronym for Qualified Health Information Networks. So again, the the Recognized Coordinated Entity, or Sequoia, was assigned to test and designate qualified health information networks that then would have their customers, and their customers in TEFCA speak are participants. And if a participant wants some of their linked organizations also to participate, they would be called sub-participants. So you can see
We're getting into the bowels of sort of like technical details here. It's great. And listen, it's healthcare. We love our acronyms in healthcare. And I know this because, like, in my family, one of the fun Thanksgiving games is for my kids to just like play little acronyms and just like, speak in healthcare, and they have no idea what they're talking about, which is kind of fun around the festive table. But if we look at sort of like this advancement, and it's sort of, you have to sign into it, we know in healthcare there is talk about, data blocking. People, organizations that don't necessarily want to share their data. And I think for most people, it is easy to comprehend that they would want their physician, their clinical team, to know everything that there is about them to receive the best care. Yet we hear in healthcare that there's data blocking, and that's still a thing. And so, Marjorie, I'd love your perspective on just, sort of where does that exist? Why does that still exist? And do we expect that to go away anytime soon?
Well, I mean, it exists because people build businesses around selling data, right? It's that simple. I can't say that people have nefarious intentions about blocking data. It just serves their best interest. But that's why the 21st Century Cures Act has provisions that prevent that, right? That's why patients have to have full access to their data. And if you're accepting government money, you can't block that, right? I don't know this, I can't articulate the specific provisions that state that, but you can't do that. The same is true for organizations. They can't, if that information is requested under certain criteria, you have to make that information available. That's also been built into TEFCA, right? Right. So if you're going to participate in TEFCA, then you have to follow the rules and guidelines that have been outlined that draw from other pieces of regulation as well.
Holly, what would you add to that?
Oh, a lot. I think, Marjorie, you did a great job, but I think when we think about the obstacles to interoperability, dissemination of standards and technology is really a slow process because the development by HIT companies has to happen, then training has to happen, rollout, and finally adoption. And this is an area where sometimes a bad job of training and identify role-based workflows in the organization doesn't happen. So adoption is extremely slow. It doesn't happen overnight. And that leads to a lack of patience or frustration. And then the hype cycle starts for the next shiny new technical object. So I think that's one of the things. But back to information blocking, it's not only they won't get government money, they will be fined, very, very significant fines. And that's in the HTI-1 rule, if anyone is interested. And then I did want to go back, Laurie, to what you were saying about implying that there might be a particular vendor that is a blocker.
Mm-hmm.
And there are rumors flying, but we have worked very, very closely with that vendor. And I will say that one of our customers is Veradigm, and Veradigm are onesie-twosie practices. And this vendor has very large organizations. So that kind of communication between small practices and large organizations is critical. If the patient goes into the hospital, the small practice has to know what happened to the patient and vice versa. So it's really very important flow of information. And we really got down into the weeds of the workflows to make sure that this would work.
So, I mean, just to put a name on things. So like, some of the reputational things in healthcare are that, hospitals can be typically pinned as blockers of information. And, Epic as a vendor has reputation of being not fully on board with interoperability. Are you saying, Holly, that is less true today than the rumors would state? Are you saying that the rumors are evolving? I mean,
I'm saying actually that is absolutely not the case. And the vendor I was referring to was Epic. We did learn that Epic's customers have concerns about trust and security using this new TEFCA. And we know, because we've worked with them very, very closely, that Epic is completely committed to TEFCA. But if you imagine one serious wrong step that gets publicized nationally, it might kill what we're trying to achieve or really slow it down. So they want to be cautious and they want to be sure that everything is right in order for TEFCA to be completely successful. And part of that is to make sure that trust and security is present and that all players are following the common agreement.
So that sounds like an optimistic view for progress and working through what have been historically discussed as large barriers, just to sort of put words to it. Marjorie, do you share that view? And I'd love to also get your perspective from, being responsible for LOINC, one of the standards that, are really important in the sending of data, back and forth, just, the role of the actual terminologies within the interoperability space.
Yeah, well, I've never really, when it comes to, which vendors are intentionally blocking, I can't really speak to that. And I don't know if it's intentional. I just know it's about what's in their best interest, right? As a business, we all know that. In terms of, where the terminology fits into sort of this larger, maybe TEFCA discussion, you also have to agree to follow other recommendations like the USCDI, that's another acronym, the United States Core for Data Interoperability, which is essentially the minimum data sets of data elements that should be exchanged electronically. And if you use USCDI, that means that you have to use the terminology recommendations to do that. So LOINC for sharing observations and laboratory results, SNOMED CT for clinical findings, etc. CPT and ICD are also named, and you have to agree to use those in accordance with those recommendations, because that's how larger policy initiatives like TEFCA exceed or succeed, because people have agreed to do that. The challenge is sometimes, I think, with US regulation is how far do they mandate, right? Mm-hmm. And I think that's, Holly, I'd love to hear what you think about that, if that's okay, Laurie.
Yeah, absolutely. And you already know that Holly's put out like big fines coming. So.
But I mean, in other sort of single payer countries, there isn't a lot of choice. Here, it's third party payer. It impacts how regulation develops and is adopted. So,
Marjorie, I think that's a great question. And part of the slowness that we're all frustrated with is that we have, and USCDI is a great example. We have that evolving over time and getting better and better and more going deeper and deeper into the information that really has to be communicated back and forth when you're taking care of patients. And yet, we're on a much earlier version than what they're working on now, because the developers of EHRs and health information technology have to continually be working on these things. So they have so much mandated right now in order to get certified that it's hard to go even faster. And that's so frustrating for everyone.
Right, we just released version 5 of USCDI. We made comments on that. We should be hearing about that today. I think ONC is going to release what USCDI version 5 is, but most people are on version 2, correct?
That's what's mandated.
Right.
To be certified.
So in terms of that,
and Laura, I just want to add one other thing, because I'm sure this drives Marjorie absolutely crazy. Not only there are electronic health records that aren't certified, and that they have their own developed codes that have nothing to do with our standard codes. They're just they just said, oh, we'll code this as this. And so those have to then be translated into the standard codes. So that's still going on. It's a really, it's a tangled web.
Semantic interoperability, right? That's what we just learned at the beginning of this.
Right.
Semantic interoperability. There's our problem.
Right.
So, but the slowness of this, let's talk about, the onset of AI. That is moving at lightning pace, and AI, in terms of all the systems that are out there that are using AI, generative and other, that's just only creating, enormous amounts of new data and information to be exchanged. Can that help in the speed of the details of the data exchanges and how those need to line up? Do you see any potential for progress there, or not? Those faces say no.
Well,
I do. I think
yes. Go ahead.
In terms of AI, some of the things that I'm excited about are, if I want to look for everything that's related to this diagnosis, and I could find all the records that are related to that diagnosis, that reference either that diagnosis or treatment for that diagnosis or Medicaid, etc. Because we do have to explain why we're ordering something, and so they become linked. So if I wanted to treat someone and I wasn't quite sure what the path had been in the past, that would be terrific, to be able to have AI go out and just fetch, or in everything that has come in, search through it and just present to me in my EHR that example.
So great opportunities for usability. What else do you see, Marjorie?
Well, I actually see AI helping with those EHRs that don't use the standard. So they've got their own local terminologies. They're not mapped to the new ones. They're, they need to move to the latest version of USCDI, but they need to at least be using the standards, and AI can help with that because mapping is labor intensive. If that type of thing happens and other things follow suit, then I think that we can move more quickly and sort of mandate more quickly later versions of important standards like USCDI that help us get to the interoperability that we're looking for. Does that make sense?
It does to me. Now, listen, I know that we could go like for a long
Forever.
time on the details of these standards, and I'm sure there's more acronyms we haven't even begun to touch on. But I actually wanted to go back a little bit. It is, you clearly are both luminaries, experts, and leaders in this really important space. And I'm hearing a bit of optimism and hopefulness that even though it's been since 1996 that we've been really trying to advance in the space of interoperability, I just love to get a perspective. It's this is, it's kind of a little bit of a nerdy space, and I would say it's more it's less of a women-led space than other spaces of technology. So I'd love to get a perspective as clinicians, as women, as leaders. What drew you into being the experts that you are in this particular space? Marjorie, do you want to start first?
Yeah, I mean, I've always wanted, I'm a clinician, right? And I went to medical school and residency, practiced for a while, but really wanted to figure out how we could get better data to help us get better outcomes. It's really that simple, right? And so that's what led me to get a master's degree in interoperability, and that's what brought me here. I think one of your other questions, Laurie, is it is definitely a male dominant space. It's generally not a place for women, but the numbers are growing, right? And women have made significant contributions to informatics. Quite frankly, Laurie, people still talk about Laurie McGraw at the AMA, and they do. And I think of people like Suzanne Bakken, who's a professor of research at Columbia School of Nursing, and Karen DeSalvo, who was the ONC director and is now chief health officer at Google Health. All of those people, women are making great strides. So I've gone a bit off topic, but I just myself I just have an interest in figuring out how we get better data to get better outcomes.
Well, you've committed your entire career to it, and you continue to advance it. Holly, how did you catch this bug?
First, I want to mention that we have another icon, Marjorie Rallins.
And yourself, Holly Miller.
And it's what you've done is phenomenal in your career. But I think I already referenced I realized the potential for electronic health records. And it just struck me. And at that time, I was so naive to how complex this is. So I really started getting more and more involved in health information technology as I was practicing. Because I recognize my passion really is trying to make an impact to improve the state of people's lives. And I believe that getting health information technology interoperability right is a strong path to being able to impact many people.
If we think about the future, and just having spent, what has been decades professionally for both of you towards making advancement, and whether it's been, significant advancement in just the past 10 years or going back 25 years, If you could both wave your magic wands and think about what you want to have done in this space in the next 5 to 10 years, you know, giving it more than tomorrow, but giving it, you know, not so far out in the future. What does that look like? And what is it going to take to get to your vision of where you want us to be in the space of standards, data exchange, usable data? Holly, why don't you start?
Well, you did mention that we had a magic wand, right?
Yes.
I think with my magic wand, I really would want every applicable healthcare constituent interoperable on TEFCA and obeying the common agreement or following it. We already talked about that it will be a slow process. So, but I am optimistic for the time frame that you referenced. And the other thing that we kind of touched on is I want to eliminate the facts. And I have a good friend, Jack Hathaway, who would say, I want to axe the facts.
I can't believe the 70% number of you know, physician offices still faxing results. I wouldn't
I can't
know
even
it's
emphasize
part of a fax machine anymore.
how
Right.
useless a fax is, because you have no data in your system. You just are
No.
reading. And then to eliminate the use of non-standardized codes, really to have the standard, you know, that everything mapped perfectly, like physicians document in ICD-10, but and Marjorie will speak to this, but what is most used is SNOMED. So there has to be a standard mapping across those two, or that we require using only one. So standardized codes to me is essential. And then bringing LTPAC into the picture. So having the LTPAC electronic health records require certification, and also to include LTPAC in Medicare quality-based payment adjustment.
What is LTPAC? What is LTPAC?
Oh, I'm sorry. You promised more acronyms. I'm happy to oblige. Long-term post-acute care, home health,
Right.
hospice, skilled nursing facilities, rehabilitation facilities, that whole
full
realm of
ecosystem of systems that support all angles of the healthcare space. That's great. That's a big ask of your magic wand. Do you think we can get there?
I think your time frame is probably not inaccurate, but I do think we'll get there.
Awesome. Awesome. Marjorie, you have the wand now.
Well, yeah, I have two wishes with my magic wand. One is it's very practical. People say it's naive, but I'd like to see us use clinical standards like SNOMED and LOINC and RxNorm, that's the one for drugs, natively in new electronic health records. But I know that's a long way off. It may never happen, but that would solve a lot of problems right now. Just like you natively code in ICD and CPT, you can also do that with the clinical terminologies as well. The more lofty goal for me, if I could wave a magic wand, it would be to achieve as a nation health equity, i.e. when everyone can attain their full health potential and there's no limit from achieving that potential because of your social position or other factors that affect that. To me, that's why we're doing all of this work, right? When you look at the big goal. Interoperability is a big piece of that. But you agree, Holly?
I want you to have the magic wand. I completely agree.
It solves so much. It solves so much. It bends the cost curve. It improves the outcomes across the nation. It improves society in so many ways, tangible and intangible. Yes, you get to keep that magic wand, Marjorie. We are all here for it and with you and support you. I think so this has been really a robust conversation. I just want to close on one simple question for both of you. The Inspiring Women is here to showcase exceptional women leaders, which you both are, but also to really inspire others, the next generation of women, to move into leadership because of the power of that and what it can be done. So just if you could just share your best advice for others who want to be like you, both of you, each of you, that maybe worked for you or that you like to share with others just as they sort of, move in their own leadership journeys. Marjorie, do you want to handle that first?
Sure. So I often mentor other people that are joining this field, coming from clinical care, whatever, and most of them are women. And I give them 3 pieces of advice, particularly women of color. I say, don't let the imposter syndrome stop you from pursuing your goals, because women are often considered to be imposters in this space, right? So you can't adopt that persona for yourself. The other thing is to stay curious and take risks and embrace new experiences, because women, studies show, although many won't believe that, are risk takers, right, by nature. And then the third thing, which I always tell women and women of color, is to lift as you climb. And that's sort of my motto. It's a driver for me, because then that helps others and it helps the profession improve. So those are my 3 things.
Thank you for that. Holly?
So Marjorie, I cannot believe you brought up imposter syndrome, because that's where I was going to start.
Right.
When I was in medical school, I don't remember what the context was, but there was a group of only women in medical school together. And we started talking about, well, I think that really they made a mistake when I was admitted. And every single woman in that group had that, at some level, had that feeling deep within them, which is imposter syndrome. And so I want that killed off. I just want women to be,
Right.
and men go into the world confident, and I want women to be as confident. And then one other piece of advice, follow your passions, obviously, but and base your decisions on what you want to do. But I want to leave one other thought, which is, I wish I had done this. As you imagine now your future career, imagine yourself as an elderly person and you're retiring, and think of the things that at that stage in your life that you reflect on as being most important, and then ensure that you include them in your plans. I think a lot of women don't want to be mommy tracked, and they actually end up spending less time with their children and families than they would have wanted to.
Mm-hmm.
This is such great closing advice and also magic wand comments. And I really appreciate both of your perspectives on this. I really want to close out this Inspiring Women conversation with a sincere thank you both for the leadership and the work that you do to make the entire ecosystem of healthcare better for all people. I think that's just incredibly important. It may be slow, but the continued work that you both do and lead is imperative to making it happen. This has been a great Inspiring Women conversation. I've been speaking with Drs. Marjorie Rallins and Holly Miller, and thank you, doctors, both very much.
Thank you, Laurie.
It was a pleasure. Thank you.
This has been an episode of Inspiring Women with Laurie McGraw. Please subscribe, rate, and review. We are produced at Executive Podcast Solutions. More episodes can be found on inspiringwomen.show. I am Laurie McGraw, and thank you for listening.